Okay, good morning, everybody. Welcome to the August Pediatric Readiness Program Education session. You'll see on the screen right now a slide reminding you how to join the audio portion. So please just follow those instructions. Feel free to use the chat box or question box throughout the presentation. And with that, I am going to turn it over to Dr. Burns and Dr. Sales to introduce themselves.
Hi, everybody. I'll go first since my name's on the left here. My name's Beech Burns. I'm a pediatric emergency medicine physician at OHSU. And here, let's do this. And the pediatric medical director for the PZD at Doernbecher.
And hey, I'm Justin Sales. I'm one of the pediatric emergency medicine physicians at Randall Children's Hospital.
Okay. Okay, how's that? Rachel, can everybody see the presentation slide?
Looks good, thank you.
Okay, excellent. Well, thank you everybody for joining us this morning. Welcome to COVID-19 in Kids. This is the inaugural session for the Pediatric Readiness Program. We sent around a kind of an email description to a lot of quarters, sort of describing what we are and what we do, but basically we're a group of physicians, nurses, and public health professionals who care about pediatric emergency care. Our goal is to partner with hospitals in Oregon and Southwest Washington like you all, using education, some logistical support, and quality improvement tools to optimize care for children in EDs in our region. I have to confess, I tried to get a picture of Sales and I's kids up on this slide, but I couldn't figure out how to get it from my phone to the computer. Which I hope doesn't speak to the quality of the talk, so we'll just see how it goes. Firstly, we have no financial conflicts of interest related to this talk, although I'm pretty sure Justin has been manufacturing hydroxychloroquine in his basement for about 4 months, but we're not going to talk about treatment, so that's not actually a conflict of interest. Second, we're not infectious disease specialists, and we're not epidemiologists. What that means is if we get questions about the S protein on the coronavirus outer membrane or the details of the basic reproduction number, we may accidentally drop the call. What we are is emergency department physicians, and so we can promise some levity. Hopefully there's some useful clinical information in here, and then maybe a little bit more levity. So here's what we're going to cover today. First, the epidemiology of COVID infection. Where are we now in terms of numbers as far as we know? Next, we'll look at the transmissibility of COVID in kids. This obviously is really important from a public health perspective, as we've been talking a lot about whether to open schools or not open schools, giving guidance around quarantine, and in estimating the true burden of disease in kids. We're going to look at the presentation of acute illness from the early evidence to our current understanding. What are the symptoms and how sick do kids get? We're going to talk about various available tests for COVID and what the results mean. And we're going to talk about changes in pediatric emergency care peripheral to COVID. So how is the COVID pandemic affecting the non-COVID pediatric patients in your ED? Lastly, we're going to review MISC and how it differs from acute infection. And with that, I will turn it over to Dr. Sales, who incidentally can get you a really good deal on hydroxychloroquine.
Great. Thanks, Beech. Are you able to see my slides okay?
Looks good.
Yes.
Great, thanks. I appreciate the shout out for my basement business. There will be a link at the end of this talk to be able to purchase my hydroxy infused products. So look out for that. Our understanding of this disease is rapidly evolving, and what we share today may be different tomorrow based on emerging research. Our hope is to provide a quick summary of some data on COVID in children, as Beech mentioned, looking at transmission, acute infection. Obviously not comprehensive, but we're hoping to highlight some themes and a few key articles and reports. So, where are we now? The United States has seen about 380,000 pediatric COVID-19 cases, and Oregon has had about 2,800 of those cases. Interestingly, from July 9th to August 6th, around 180,000 new pediatric cases were reported, which is a 90% increase in job cases over those 4 weeks. And 70% of that increase, which people are likely seeing on the news, has been occurring in the South and Western United States. Now, children represented around 9% of all reported cases in the US, with Oregon's pediatric cases making up about 14% of our total cases within our borders. Now, another way to look at this is cases per 100,000 children. So calculated using state-level population estimates, the overall rate of the US is around 500 child COVID cases per 100,000 in the population. As Oregon has around 950,000 children, our current case rate is around 300 per 100,000. Now, we look at these numbers for policymaking, for mitigation strategies, and this additionally becomes an important metric for school reopening. Now, here's a quick slide for those parents listening, and for those of you that are desperately awaiting school to reopen, you may want to close your eyes during this slide. Current Oregon Department of Education guidelines require for a school to return to in-person instruction, the case rate for their school county must be equal to or less than 10 cases per 100,000 population for grades 4 and above, and 30 cases per 100,000 for K through 3rd. There are 4 counties depicted above, and the dotted line represents where we need to be to open those grades 4 and above, and the dashed line represents where we need to be to open K through 3. So we have a way to go. Okay, parents, you can open your eyes again. So, there's growing interest in the role that children play in transmitting the virus. There's actually tons of great contact tracing articles, and I'm just going to try to highlight a few. Interestingly, in most of these reports, children are the index case in few households. I think we're seeing real-world evidence pointing towards a limited spread of COVID between children and from children, which completely challenges my idea of all children being the super transmitters. Now, this Australian study examined COVID transmission among children and adults in 25 educational settings, together with the rate and characteristics of all pediatric COVID cases in New South Wales over a 3-month period. They found low case rates and secondary infections amongst children and staff attending those educational facilities, and this was throughout the first epidemic wave. They did note the transition chains, though, between staff and from staff to children were apparent, but the child-to-child or child-to-staff transmission appeared unlikely to have occurred, but they could not completely exclude that. Additionally, there was another small study from Ireland following 6 COVID positive cases in 3 schools. It was over a shorter time frame, just a little less than 2 weeks, and they suggested no transmission to over 1,000 close contacts. This Icelandic study was interesting. It compared targeted testing, meaning those individuals that were living in Iceland who were high risk for infection. So they looked at those who were symptomatic, had recently traveled to high-risk countries, or had contact with infected persons, and they compared that to just a general population screening. A total of 13% of the over 10,000 people who were recruited for the targeted testing, meaning those high-risk individuals, had positive results for COVID. And of those tested in the general population, less than 1% tested positive. And they were able to test around 6% of their total population. The main point here is children under 10 years of age were less likely to be positive for COVID than were the persons 10 years of age or older, with percentages of 7 and 14% respectively for that targeted testing, meaning that high-risk group. And in the population screening group, no child under 10 years of age has a positive result. So again, this population-based study, I think, illustrates what we're seeing in the U.S. with children under 10 years of age having a lower incidence of COVID infection than adults or adolescents. As we all know, Spain is one of the European countries that have been most affected, and serological surveys are a very valuable tool to assess the extent of the epidemic given the existence of asymptomatic cases. This nationwide population-based study selected over 35,000 households, and they looked at it from April to May of this year, and they had over 61,000 participants. And those participants agreed to answer a question on history of symptoms compatible with COVID, their risk factors. They all received a point-of-care antibody test, and if they agreed, they donated a blood sample for additional testing. Their results indicated that children had a lower seroprevalence than adults. Specifically, they noted 3% in children less than 10 years of age versus 5% overall. Of interest, the study reported that at least a third of the individuals who had developed antibodies against COVID were asymptomatic, which of course has important public health implications. There's now extensive literature on household transmission involving children, and these have reported that children were less susceptible to COVID than adults in the home. In an unpublished preprint, one article identified 31 household transmission clusters that children were involved in, and they were looking at families in Singapore, China, the US, Vietnam, and South Korea. And in only 3 of the households, meaning 9%, they were able to identify the child as the index case. The authors compared this with household transmissions during the influenza virus, where children were the index case in 54% of households. An additional study examined over 400 household clusters and reported there were no cases where the index individual was below 15 years of age. So key point, the data suggests, at least to date, that the young children have not driven the household transmission of COVID and seldom led to outbreaks. Now that we shared a little bit about this perceived limited disease burden in children, Dr. Burns will speak a little bit about acute infections.
Are we back to my screen? Can you guys see that?
Yep.
Okay, excellent. Thanks, Justin. Always upstaging me with the pre-published data that nobody else has access to. Kudos. Hats off to you. So yeah, looking at acute infection in kids, this is one of the things that I was really excited to sort of shore up my knowledge on this talk. I think there's been a lot of conflicting data about acute infection, MIS-C, so I'm hoping to sort some of that stuff out, and really like help differentiate between, to the extent possible, clearly between acute infections and MIS-C. Justin just talked about the number of infected in the United States, which I'll come back to later, and we'll spend some more time with MIS-C at the end of the lecture. And we'll talk about how much MIS-C that we're seeing so far. The quick spoiler is not very much. But first, let's look at the clinical course and presentation of acute COVID infection in kids. Shoot, sorry guys. Give me 1 second here. Having troubles. Oh, this is it. All right. So one of the earliest studies from China, which as we all know is kind of where this began, so they had a lot of the early data. This was published in Pediatrics by Dong and his colleagues in March of 2020. They described over 2,100 kids with COVID-19. They looked at age, demographics, and very importantly, the severity of illness. This study looked at both laboratory confirmed patients and those suspected based on their symptoms, their labs, their x-rays, and their exposure history. The important thing to know is that 1/3 of these kids were lab confirmed and the other 2/3 were suspected. It was kind of the best we had at the time, but that's important to bear in mind as we look at the results. The average age for the infected patient was 7 years. Confirmed cases tended to be older than suspected. Very interestingly, asymptomatic, mild, and moderate illness, if you put it all together, accounted for 94% of cases, which meant that about 6% of all cases were severe, critical, or could not be determined. It's, to know what that means, we have to know what those categories mean. And according to this study, and pretty much everyone that's followed, they defined that as asymptoms means what you would think, so no symptoms, normal chest x-ray. Mild were symptoms of a URI and no pneumonia on x-ray. Moderate was cough and the patient was ill appearing, or they had pneumonia on x-ray. Severe was oxygen requirement because their O2 sats were less than 92%. They needed respiratory support, or they had severe respiratory distress. And critically ill kids were those who needed ICU admission, intubation, multi-organ failure, or any of those other really bad things that we think about. Obviously, the striking early finding from this study was that COVID in kids seemed to be pretty mild, in stark contrast to what we were seeing with adults. Though in this study, at least, there was a slightly higher incidence of severe disease in infants compared to older kids. Again, remember, 2/3 of these patients were presumed or suspected COVID, but not laboratory confirmed. So the question was, would this data hold up as more information emerged? We also didn't get any real idea from this study what symptoms kids were presenting with. So the next major study, and like half these articles were published in the New England Journal of Medicine because this was all new information, you know, on the leading edge of a pandemic. So there was a rush to publish and get this stuff out there. But this study was from Italy. They looked at kids in the month of March presenting to pediatric emergency departments, but they limited their results to kids who had a positive PCR. The average age of kids in this study was quite a bit younger, 3.3 years. 40% of them were under the age of 1 year. The most common symptoms were cough, 44%, fever in 39%, difficulty feeding in 23%, and rhinorrhea in 22%. 12% looked ill, but only 4% had an oxygen saturation less than 95%. The other thing to know is that of those that got sick and needed respiratory support, 6 of the 9 had underlying medical conditions, which was a little bit contrary to what we saw in the previous study. 21% of these kids were asymptomatic, 58% were mild, 19% were moderate, 1% had severe disease, and 1% were in critical condition with no patients dying. In this study, infants tended to have mild disease, and I mentioned patients with comorbid conditions tended to get more ill, which was kind of a new finding. So a little bit of conflicting information from the two studies, and this study only had 100 kids in it, so it was relatively small, but a map of the disease severity was starting to emerge, and it looked like COVID in kids was not that phenotypically severe. Okay, May 2020, we got our best picture of acute COVID infection in kids to date. This was a systematic review, meaning they looked at all the studies that had been done from January to May of 2020, which captured 62 studies, 3 reviews, for a total of 7,480 kids. So a pretty large sample size. They looked at clinical data, laboratory data, radiographic, and they included only confirmed cases of COVID, unlike that first study that we looked at. The average age was about 7.6 years. The large majority of cases were from Italy, the US, or China. They used the same description of disease severity that we talked about before, and they found that 15% were asymptomatic, 82% were mild or moderately ill, 2% were severe, 0.6% were critically ill, and 6 patients died, which translates to 0.08%. In terms of presenting symptoms, most commonly pediatric COVID looked kind of like adult COVID. Surprise, surprise. Yet predominantly you had fever and cough with some sore throat, runny nose. Close to 10% had GI symptoms. So that was some abdominal pain, diarrhea, vomiting. Usually that preceded the onset of respiratory symptoms. One major difference was that dyspnea was pretty uncommon, which is not surprising given what we've talked about about the disease being generally less severe. And only 3.3% required oxygen for O2 sats less than 92%. Importantly, they also looked at lab and x-ray findings, which, at least for us early on in the pandemic, we were just sort of getting the, shotgunning labs to sort of see what we could pick up, hearing that lymphopenia might be common, that sort of thing. There were 655 kids in 38 studies looking at lab profiles of COVID positive kids. The striking finding here in my mind was that full blood counts, including white blood cell count, platelets, hemoglobin, hematocrit, were in the large majority of patients totally normal. Only 17% had leukopenia, so low white blood cell count, while 13% had lymphopenia or neutropenia, and only 13% had a high white blood cell count. Platelet abnormalities, either high or low, if you put it together, that was 15% of patients. Elevated inflammatory markers were seen in 30% of patients, which is sort of useful, but you also see that with just about every condition, right, that we're looking for in kids if we're worried about infection. And then CPK and transaminase were occasionally elevated, though to me, none of this is that helpful. In terms of radiographic findings, there were 674 patients from 40 studies. Yeah, I think it's worth noting that about 50% had abnormal findings. The most common was ground glass opacities, followed closely by unilateral patchy opacities, and then by bilateral patchy opacities. At least up until this point, most of the studies had been CT scans, which was sort of predominantly what they were doing in China and Italy, not chest radiographs. The noteworthy thing is that if you look at these individual studies, the abnormality rate for chest x-rays was also about 50%. I think that what that means to me is we don't need to warm up the CT scanner for every kid when we're worried about COVID. A chest x-ray will probably do. Okay, and then lastly, what about neonates? I mentioned from that large Chinese study, it looked like maybe they got more severe illness. From the Italian study, it looked like maybe it was actually more mild. So what did this review of the accumulated data tell us? There's not that much data even at the time of this study, but among the 25 newborns from case reports and case series, the distribution of disease severity was pretty similar to older kids, 20% asymptomatic, 48% mild, and 20% moderate. There was a slightly higher percentage, 12% of severe cases. And the most common presenting symptom in infants was dyspnea at 40%, compared to older kids, which, if you remember, was probably 7 or 8%. Cough was rare, which is interesting, only 2 of 25 kids, but fever and feeding intolerance were pretty common. Labs, again, were generally not helpful. As far as radiographs, fortunately, most of these kids got chest x-rays rather than CTs. And again, the rate of abnormal studies was about almost 50%. The most common finding here was unilateral patchy opacities rather than that typical coronavirus ground glass or bilateral infiltrates. So the takeaway for me from this data for young infants is that they're still likely to do pretty well with coronavirus, 88% having moderate or less severe disease. They are more likely to present with dyspnea, fever, or feeding intolerance. So your threshold for suspicion should be higher if a kid comes in with one of those symptoms. But labs, other than a coronavirus test, labs are not going to be super helpful in figuring it out, though an x-ray can be. Okay, so hospitalization rates. Dr. Sales reported the most up-to-date numbers we have for pediatric COVID cases. In the US, according to my review of the CDC website last night, we have about 5.1 million cases in the country. Of those, 7.5% or 380,000 cases were kids under 18. Now, I just described the accumulated data. We know about 2% of patients have severe disease. Given that, we would expect hospitalization rates to be pretty low. And that is, in fact, what we're seeing. This graph on the left depicts laboratory-confirmed hospitalizations for COVID in the United States over time, both for all comers, which is the black line kind of in the middle, and broken up by age group. The red line at the top represents patients 65 and older, by far the group at the highest risk for hospitalization. Below that is 50 to 64. The black line I mentioned is the overall rate. The blue line below that is age 18 to 49. And the orange and purple lines at the very, very bottom, kind of overlapping, are kids aged 0 to 4 and 5 to 17. This sort of gives you an idea of the relative risk, but numerically, what that means is that people 65 and older experience hospitalization at rates of 378 per 100,000, while pediatric patients are hospitalized between 7 and 12.9 times per 100,000. This means that adults over the age of 65 are 29 to 53 times as likely to be admitted than patients under the age of 18. So quickly revisiting what we're seeing in Oregon, the total pediatric population in the state, Justin mentioned, is about 960,000. We've seen a total of 2,800 cases. The total number of cases in our state, adults included, is 19,979 cases. That means kids are 14.5% of the total. Of these cases, 41 have been hospitalized out of a total hospitalization number of 1,726. That means kids have accounted for 2.4% of total hospitalizations in the state, and that of kids who are diagnosed with COVID, 1.4% get hospitalized. The importance of that, what that means to me, is that if you as a provider, as a nurse, have not seen a kid who's COVID positive that you've admitted to the hospital, it's probably not because you're missing a ton of these kids. There just aren't that many. 41 hospitalizations in the state so far. This graph on the right, if you start doing locums in California, you may be in a different situation. And we'll see what happens as coronavirus numbers, as the graph that Justin was showing about school reopenings, as the numbers continue to increase, I expect we will see more kids who get sick. I suspect that the hospitalization rate will still remain pretty low. Okay, and with that, I'll send it back to Dr. Sales.
Great, thanks, Burns. So the question, of course, as Dr. Burns has illustrated, is why the lower numbers? You know, the pediatric population has classically been viewed to be highly vulnerable to infectious diseases. I think we see that in our clinical practices. And the CDC considers children, especially those younger than 5, as a high risk for influenza-related illness. But as we're all experiencing, this age distribution of patients with COVID is very different than, say, those of our experiences of H1N1 back in 2009. And there's several published sort of explanation for this milder disease in children. The first explanation is that the immune systems of children and adults are different in respect to their composition and their functional responsiveness. Milder disease presentation might be due to the child's trained immunity. Of course, their frequent viral infections and vaccines in kids induces an enhanced state of activation of the innate immune system that can result in more effective defense against different pathogens. And this may explain the more severe infection that we see in very young infants. Additionally, the adaptive immune response may also play a role in COVID-19, as the adults usually have a decreased lymphocyte count, and children infected with COVID, as Dr. Burns mentioned, typically have normal lymphocyte counts, secondary to those frequent viral infections experienced during childhood, and hence frequent activation of the immune system. A third possible explanation are the differences in expression of an ACE2 receptor. So there's many articles illustrating this ACE2 receptor as an entryway for COVID. These receptors are necessary for binding the COVID-19 protein for entry into the host cell. The results of one study showed an age-dependent expression of ACE2 receptors in nasal epithelium, which is a potential first point of contact for COVID in the human body. Now, what they found was this ACE2 receptor nasal gene expression was greater in adults, as illustrated by the graph. The expression was significantly lower in 4 to 9-year-olds, as you can see on the left side. It was higher in the 10 to 17-year-olds, but still statistically significantly lower than adults. Now, this particular paper only looked at individuals between the ages of 4 to 60. And as you can see, the data was reported just by age categories. So it's still unknown, and I wonder, as a parent of a middle schooler, is there an uptick during or after middle school, saying our 10 to 13-year-olds? So as we know, testing for COVID enables infected individuals to be identified, and then we can help isolate them, and allows us to perform contact tracing, and it provides knowledge of regional and national rates. Now, this slide shows briefly the current CDC recommendations for who to test, although we all likely have facility-specific recommendations just based on our testing availabilities. So a little bit about current testing and their characteristics. So current testing involves looking for the viral RNA, proteins, or antibodies. Acute infection typically involves testing for viral RNA or proteins, while the serologic tests have the aim of detecting individuals who have had previous infection and therefore theoretically developed immunity. Antigen tests don't require the expensive equipment and chemicals needed to perform PCR, the nucleic acid tests, and they are more easily used as point-of-care tests, but with less sensitivity. Now, it's important to note that these diagnostic tests can be inaccurate in two ways. A false positive result incorrectly labels a person infected, with the consequences including unnecessary quarantine and additional contact tracing that's not necessary. False negative results are more consequential, though, because those infected persons, who might be asymptomatic, may not be isolated and can infect others. A recent systematic review of the accuracy of COVID tests reported the false negative rates between 2 and 29% based on negative PCR tests, which were positive on repeat testing. Now, the accuracy of these viral RNA swabs in clinical practice varies depending on the site and quality of sampling. In one study, looking at 205 patients through PCR testing, the sensitivity for bronchoalveolar lavage was around 93%, sputum was 72%, 63% for nasal swabs, and only 32% for throat swabs. Now, of course, this accuracy is also likely to vary depending on the stage of the disease, degree of viral multiplication, or clearance. Now, one community-based study in China with over 4,500 close contacts of patients with COVID were tested by PCR throat swabs every 48 hours during their 14-day quarantine period. And of the around 130 that were eventually diagnosed with COVID, only 92 had a positive test on that first throat swab, equating to a sensitivity of 71% in this lower prevalence community setting. So, as noted, while these positive tests for COVID are clinically useful, I think this is illustrating that the negative tests need to be interpreted with caution. The false negatives do carry substantial risks. Patients could be moved into non-COVID hospital floors, which could lead to hospital-acquired COVID infection. Carriers could spread infection to vulnerable dependents, and I think us as healthcare workers risk spreading COVID to multiple vulnerable individuals. This does illustrate the need for clear evidence-based guidelines on repeat testing to help reduce the risk of false negatives. So, what should we do about this in our clinical practice? And I think it strongly advocates for us to talk about these limitations with our families. I would suggest it's important to review with them that, no test is 100% accurate. I think sharing that if your swab test comes back positive for COVID, then we can be very confident that you do have it. However, people with COVID can be missed by these lab tests. And if you have strong symptoms, it's really safest currently to self-isolate and keeping with the current guidelines for suspected COVID, even if the swab test does not show COVID. So now leaving test characteristics, we think it's important to talk briefly in the larger scope of this pandemic about potential collateral concerns. Now, since the coronavirus pandemic started spreading across the U.S. and state governments were issuing stay-at-home orders, millions of us have isolated ourselves to avoid exposure. And this has led to several additional pediatric and family concerns. Non-accidental injury is often considered to be a silent pandemic, and emergency departments are reporting an increasing number of non-accidental injury cases. Some European countries have reported an alarming increase in domestic violence by 1/3. The sudden withdrawal of schools, the youth programs, and the time with other relatives really takes away not only that respite of childcare, but also the early warning system that these places would have normally provided for kids. Multiple case series have reported delayed emergency presentations to the ED as well for fear of contracting COVID-19. Additional factors like cancellation of outpatient clinics, postponement of elective procedures, and of course the redeployment of staff and reallocation of resources have all impacted patient care. So we really need to be able to support families to seek prompt medical treatment for their children in a timely and efficient manner. It's important to share that this current pandemic may additionally be leading to worsening anxiety and depression among children because of this unique combination of the public health crisis, the social isolation, and of course the economic recession. As we know, schools have long served as a proxy mental health system for many children and adolescents. Although not recent data and analysis back in 2015 found that over 12% of adolescents received some sort of mental health services from a school setting corresponding to 3 million kids, which of course is lost when the schools have been closed during the current crisis. Another result of families staying in home is parents across the country have canceled their pediatric well visits, and therefore the immunization levels for vaccine preventable diseases have dropped. Now this graph is showing Oregon's total monthly vaccinations between January and April in 2019, the gray line on top, versus current 2020 as the blue line, as a percentage of our 2018 totals. You can clearly see that we've had around a 25% decrease from last year. Although we previously discussed a limited illness burden in children, the school closures, the social distancing clearly disrupts the lives of students and their families and may have additional consequences for the overall child health. And moving forward, we almost considered what can be done to mitigate this. So now Dr. Burns will take a moment to review the mysterious MISC.
He definitely will if he can get his PowerPoint to come back up. Okay. There we go. So yeah, thanks, Justin. Last thing, there's lots to cover, so I'll try and I've never been accused of, people say I talk too much is what I'm trying to say. But I'll try and get through this as quickly as possible, though it's really fascinating. Multi-system inflammatory syndrome in children. There's been a lot of press around this entity and some justifiable alarm because of how severe it can be. I want to talk about what it looks like, how it's diagnosed, and how common it is. In other words, how many of these 380,000 patients in the United States with pediatric coronavirus do we need to worry will develop it? First, let's talk about what it looks like. In late April, physicians in the UK recognized increased reports of previously healthy kids presenting with a severe inflammatory syndrome with features similar to atypical Kawasaki disease, Kawasaki's disease shock syndrome, or toxic shock syndrome. All initially tested negative for COVID PCR, though 2 subsequently tested positive, but 4 of 8 had known epidemiological links. The presenting symptoms for these kids were high and persistent fever, rash of some kind, conjunctivitis, peripheral edema, extremity pain, and GI symptoms like abdominal pain, vomiting, and diarrhea. Of note, only 1 of these kids had respiratory symptoms. The alarming thing to these investigators was how sick these kids were getting. Every one of them progressed to warm shock, requiring volume resuscitation and vasoactive medications. They all had elevated inflammatory markers. 7 of the 8 had significant cardiac involvement with echo bright coronary vessels, with 1 of them having giant coronary artery aneurysms within a week of discharge. 1 of these patients died due to refractory arrhythmia with shock, requiring ECMO ultimately, and eventually dying from a large stroke. At the time that this was published, they had 20 other patients under investigation for this entity. So they were really sounding the alarm that this was a new and dangerous phenomenon that was emerging. This is really what kind of got everybody investigating this phenomenon paying close attention. This was only 8 kids. So what have we found since then? I think this is the best we have so far. This is multisystem inflammatory syndrome in US children and adolescents. It's a retrospective and prospective surveillance study on all patients admitted from March to May across 53 sites in 26 states in the US. Came out in June in the New England Journal of Medicine. What they did, they used the CDC case definition when they collected data from all of these centers. That definition is listed here, and basically to meet criteria for MISC, you have to be less than 21 years, you have to have fever or subjective fever greater than 38 lasting more than 24 hours, you have to have laboratory evidence of inflammation, and that's ESR, CRP, low lymphocyte count, high neutrophil count, elevated ferritin, that sort of thing. And you had to have evidence of clinically severe disease leading to hospitalization with multi-system organ involvement. And that could be cardiac, renal, respiratory, hematological, gastrointestinal, dermatological, neurological, or whatever other organ system I've never heard of. You had to be positive for SARS-CoV PCR or serologies or have an epidemiologic link to a person with COVID, which meant close exposure to that person within the 4 weeks prior to onset. And there couldn't be an alternative plausible diagnosis. I had a kid who had disseminated MRSA infection, who I was sure had coronavirus, but he grew MRSA from everywhere. So even though he met these other criteria, that wouldn't count, right? They collected data on 186 total patients during this time. Slight male predominance, the average age was 8.3 years. 73% of these kids were previously healthy, though obesity was slightly more prevalent in this sample than in the general population for age. 70% were PCR or serology positive, the other 30% had an epidemiologic link, and 71% of kids had involvement of 4 or more system involvements, with GI being the most common. 80% required ICU care, 4% needed ECMO, and 4 patients, or 2%, died. Although at the time that this report was published, 28% of these kids were still in the hospital, so who knew what was going to happen? So how did these kids present clinically? I mean, and that's what we're looking for in the ED, right? 78% had fever for 5 or more days, and 90% had fever for 4 or more days. So the kid with mild abdominal pain without a fever probably does not have MISC. As I mentioned, the most common organ system was GI at 92%, abdominal pain, nausea, vomiting, and then very occasionally you'd get like hepatitis, pancreatitis, gallbladder hydrops. Cardiovascular was the next most common at 80%, which I'll discuss on the next slide, and that is the really bad one. Hematologic was 76%, and that included lab abnormalities, clots, etc. And then you had skin, mucocutaneous, and respiratory after that. In contrast to that early study of 8 patients where 1 had respiratory symptoms were pretty common here, 70%, and 59% of all patients had respiratory insufficiency or failure. About 20% needed mechanical ventilation. Musculoskeletal involvement and neurologic involvement were seen, but not very common. Okay, cardiovascular involvement, and this is really what sets MISC apart. 80%, I mentioned, had cardiovascular involvement. Of those patients, most, or 48% of the total sample required vasoactive support. So again, at least half of these kids came in with shock. 50% fully had elevated troponins, which is really unusual for a pediatric entity, right? 33% had an ejection fraction less than 55%, 12% had arrhythmias, and 8% had coronary artery aneurysms. So all in all, severe inflammatory condition characterized by prominent GI symptoms, but also shock, significant cardiac dysfunction with some Kawasaki-like features. So when I first heard about this, I have to say I thought like, well, is coronavirus just causing Kawasaki's disease, including in older kids? How are these two really distinct? After all, they have some of the same features of KD. Cardiac involvement is the feared complication. The thing to note, though, is that more than a third of the patients, more than a third of the patients had Kawasaki disease-like features, most did not meet criteria for either typical or atypical Kawasaki's disease, a full 60%. Also, the kids with Kawasaki disease-like features tended to be younger, more often under the age of 5, which is what you see with classic KD. This table sort of breaks down a few of the key differences between classic Kawasaki's disease and MISC. MISC kids are quite a bit older, 8.3 years versus 3.4 years. They're far more likely to present in shock requiring vasoactive agents. I mentioned about 50%. In Kawasaki's disease, you see that about 5% of the time. And the risk for coronary artery aneurysms is quite a bit higher in Kawasaki's disease, 25% versus 8% in MISC. So there's still some overlap. So to me, after reading this study, I wasn't still totally clear about the relationship between MISC and Kawasaki's disease. Are they the same? Are they different? Is one a variant of the other? So let's look at the most up-to-date American data. As of August 6th, which is just a week ago, the CDC has received reports of 570 confirmed cases and 10 deaths in 40 states. Oregon has, you can see on this map, between 1 to 10 cases. Washington, which has quite a bit more coronavirus than we do, has had 11 to 20 cases. And California, with over 40,000 pediatric cases of COVID, has also only had between 11 and 20 cases. Most of it still has been reported on the East Coast. Most cases are in kids between the ages of 1 and 14, with an average age of 8 years. More than 70% of cases have occurred in children who are Hispanic or Latino or non-Hispanic Black. 99% of all cases are tested positive for SARS-CoV-2, either PCR or serology, and that last 1% are those epidemiologic links. Usually develop 2 to 4 weeks after acute infection, which is consistent with previous studies. Most of these kids presented with GI symptoms, including abdominal pain, vomiting, and diarrhea. And around half had conjunctival injection with rash, with about 50% presenting with hypotension. This is all familiar from that New England Journal study we just looked at. 86% had cardiac involvement with cardiac dysfunction, shock, myocarditis, and coronary artery changes seen. 64% required ICU and 1.8% died. Again, not too different than the large New England Journal study. Okay, but as to the question, what's the relationship between MISC and Kawasaki's disease? Are we lumping 2 entities caused by coronavirus? One that's like a toxic shock-like phenomenon, and one that's like Kawasaki's disease into the same thing? And the answer is maybe. The report that I talked about was MMWR. It was published on August 7th. They reviewed the 570 cases that have been reported to the CDC so far. They used a technique called latent class analysis, which is a statistical modeling technique that can divide cases into groups by underlying similarities. You can then use it to identify and describe differing manifestations in groups of patients who met the same MISC case definition. And that is literally all I know about it, so please don't ask me any more questions about it. What they were able to do using this technique was identify 3 groups of patients. Class 1, which was a little over a third of patients, consisted of patients who had common MISC symptoms: shock, cardiac dysfunction, abdominal pain, very elevated inflammatory markers. 98% had positive serology studies and not PCR studies, and there was little overlap with acute COVID or Kawasaki's disease. Class 2, the second group, which is about a third of patients, were characterized predominantly by respiratory involvement, which affected 3/4 of patients. They were more likely to have cough, shortness of breath, pneumonia, and ARDS. And these were the patients that were most likely to die. Very interestingly, 84% of those patients had PCR positivity, that sign of acute infection. Class 3 captured, again, about a third, captured the youngest patients. These were about 6 years compared to 9 and 10 years in the other groups. They had the highest prevalence of rash and mucocutaneous lesions, and the rate of coronary artery aneurysm and dilatation was higher than class 2, but not as high as class 1. These kids more commonly met criteria for complete Kawasaki's disease, and they had lower rates of organ system involvement, including shock, myocarditis, cardiac damage. Among these kids, 63% were positive serology, so they had the antibodies, and about a third had positive PCR and serology. I think what this means is that it's possible that what we are seeing with multi-system inflammatory syndrome is really 3 separate groups of patients. Class 1 would be typical MISC, which are older patients that are affected by this hyperinflammatory syndrome characterized by myocardial dysfunction and shock, where an autoimmune inflammatory phenomenon is just running amok. The second group, class 2, would be pediatric patients with acute COVID infection with perhaps some overlay of MISC, right? But those are the patients, remember, that had those positive PCRs. The third group, which is class 3, would be patients with Kawasaki disease-like illness. Younger patients with that inflammatory state of a lesser magnitude that weren't coming in shock. The authors even say maybe some of those class 3 kids just have plain old Kawasaki's disease and coronavirus is an incidental finding. This is all early speculation. The reality is we still just don't know, but this seems like a compelling way to parse the data to me. The last thing to say is that MISC is pretty rare. Remember, I just told you there are 570 cases in the country out of 380,000 infections. That means of that 380,000, 0.15% will develop MISC, or 1 in 670 acute infections. It doesn't mean we don't need to prepare for dealing with this in our EDs, but it does mean that we're probably not going to be overrun by these patients in a couple of months. It can be really serious, right? So I think you need to be aware of it, prepare for it, but it's not time to panic. Briefly, how do we prepare? I think developing a screening tool is a reasonable idea if your center sees a fair number of kids. This guideline is offered by the American College of Rheumatology, whose website I can honestly say I've never looked at before this talk. They basically say that when you see a kid with each of 3 criteria, you should start thinking about it. And those criteria are fever greater than 38, an epidemiological link to COVID, which is a positive test or a known contact, and at least 2 suggestive clinical features. That's rash, GI symptoms, acral edema, oral mucosa changes, conjunctivitis, lymphadenopathy, or neurosymptoms. If they're in full shock, do the full workup, surprise, surprise. If they're not, then you start a tiered evaluation, getting a CBC, CMP, inflammatory markers, and so on. And if those look suggestive, then you continue with the full workup, including lymphocyte counts, a BNP, troponin, all that stuff. If it's not suggestive, then watch the kid closely over the next couple of days, ensure close follow-up. We're going to be developing our own pathway based on this, but what your pathway looks like will depend on what resources you have locally. So to summarize, there was a lot there in that 55 minutes. I think the key points here, to summarize sort of what I covered and what Dr. Sales covered, is that with regards to transmission, young children are not the primary drivers of household transmission. They're usually the ones who get it from parents, and they're seldom the ones who lead to outbreaks. As far as testing goes, positive tests for COVID are clinically useful, but you have to be a little bit cautious with negative tests given the limitations in sensitivity that Dr. Sales discussed. Don't forget general pediatric concerns. We're seeing more NAT, more delayed presentation for care. Be aware of those things when you evaluate a patient who's there for a potentially non-COVID concern. Acute infection, mostly you're going to see fever, cough, URI symptoms, and GI symptoms. Your lab evaluation is not super helpful. X-rays might be. The large majority of patients are going to be asymptomatic, mild, or moderate. And hospitalization is pretty rare. And as far as MIS-C goes, fever, GI symptoms, rash, and conjunctival injection are the predominant presenting clinical symptoms. About half of these patients will have hypotension with serious cardiac morbidity, so be alert for that. There are possibly these 3 phenotypes, but we are not totally sure. That's just early thinking. And overall, it's a rare entity. Be aware of it, but like I said, don't panic. And with that, I will stop. We have a few minutes left for questions, so we are happy to take any that you guys have.
Please feel free to enter your questions into the chat box or into the question box. So it looks like we have a question from Christine. Does anyone know if the false negative rate is greater in the first few days of the illness? If sample is obtained on day 7, 10, 14, is that more accurate? The worry is allowing someone on a plane with 1 negative test.
Yeah, that's a great question. And there has been some data about a higher false negative rate early in the course of the illness and getting better farther out from the acute infection, which again, not only illustrates the worry with something like traveling, but also would illustrate the worry of trying to use a single test or a single negative test to determine safety, let's say, going into schools or large group settings.
Yeah, and I will say from a hospital standpoint too, that's why many institutions have a policy when a patient gets admitted, they have to have multiple negative tests before they get de-isolated. So they'll do the initial test and then 48 hours later repeat it with the thought that like if you have 2 negative tests 48 hours apart, then you increase the sensitivity. We still understand that even that's not perfect, but you kind of have to create a policy with the best data that you've got.
We have another question.
And there is a nice.
Oh,
I was just going to say it's Justin. No, that's fine. I was just going to say there is a nice published article looking at that. So whoever was interested in specifically that data, if you want to send an email to Rachel Ford following this, then we can forward that article to you for your review.
Okay, our next question is, do you have the death rate of kids in the state of Oregon and the U.S.? I know our county has none under the age of 40, but unsure of the rest of the state and the United States.
That's a good question. I didn't, the AAP and the Children's Hospital Association report out data broken down by state. I didn't see any Oregon pediatric deaths, though don't quote me on that. Justin, did you come across that in your research?
I did. Thinking about it right now, I don't have that specific number for deaths.
Yeah, I mentioned that for acute, there have been between 1 and 10 MIS-C cases in Oregon, and I think closer to 1 than 10, to be honest. There may be another one somewhere in the state right now, but and then there were 41 hospitalizations of kids. To my knowledge, none of those kids died, but I can't guarantee that. I think whatever the number is, it's very, very low, and possibly 0.
And I have a comment from Lynn Frost, and she's saying that she has not seen any deaths in children in Oregon. So thank you, Lynn, for adding that. And we'll just take this one last question because we're at 9 o'clock. Would you recommend opening schools?
Go, that one's going to you, Justin.
Unfortunately, it's such a tiered and layered question and response, which we could probably have a second hour of conversation about. I can tell you, I think nationally, when we're looking at this question, it's going to be dependent on the space of the individual school, the number of kids, the mitigation strategies that they have in place to really make that decision. Definitely based on the data that we shared here and what you're seeing nationally, putting high school students back into a small campus in large groups without mitigation strategies will lead to increased cases. But I do think, at least through the lens of the American Academy of Pediatrics, I think there's a hope that we can make that work. But it does take a lot of layers of support to be successful. So I'm sort of answering it, but not answering it. But we're definitely, at least for Oregon, speaking what are our current guidelines, we definitely won't be doing that anytime soon.
That was expertly evasive, Justin. You're getting good at this.
Yeah, thanks.
Thank you. I just wanted to thank both Dr. Sales and Dr. Burns for presenting this morning, and thank you everyone who participated. We just had a website added into the chat box. If that's of interest, it shows the current dashboard for the state. And again, if you have any questions, you can, of course, send them to me. This is Rachel Ford moderating. And my information is on the EMS for Children website if you don't already have it. So thanks again. And at this time, we will stop the recording. Thank you.
Thanks, everybody. Hopefully see you next time.